So hello, everyone. My name is Anna Rosanowski, and I'm the Chief Operating Officer of CDIQ Consulting. We are thrilled to welcome you to our free CCDS exam prep webinar series for February 2025. We understand how important it is for you to get CCDS certified, and we are here to support you with this live interactive webinar. Now I'm honored to introduce our CEO and CDI educator, Dr. Tarman Aziz, MD, CCDS. Dr. Aziz is an experienced internal medicine physician, CDI executive, and revenue cycle consultant with over 12 years of experience in transforming clinical documentation, improving case mix index, and enhancing healthcare quality. With a background as a CDI quality auditor, documentation champion, and medical education director, he combines clinical precision with strategic
And two reps.
to redefine healthcare education and consulting. Before founding CDIQ Consulting, Dr. Aziz led successful assessments.
And make sure you don't spray more than you can wipe off.
As a subject matter expert for organizations like SciAx, Guidehouse, and Clinintel, while also contributing over 15 years to academia as a medical school faculty and academic dean. Dr. Aziz will be leading tonight's session, guiding us through key strategies to excel on the CCDS exam and deepen your understanding of clinical documentation improvement. Dr. Aziz, please take it away. Thank you.
Thank you so much, Anna. Appreciate the introduction. And it's great that everybody's here this evening. Certainly do appreciate the participation in our free webinars. And today we're going to get right into doing some questions in the interest of time. The best way for you to participate in the questions is to put your answers in the chat box, but don't send it to the entire meeting group chat. Go ahead and toggle it on to sending only to me, so only I can see your choices. And any of you who feel sufficiently motivated to get on the camera or at least on the microphone to share why you think an answer is the correct answer, that would certainly be welcomed as well. So I'm going to go ahead and display the first question now, give everybody a chance to read through it. Starting to see some answers coming in to me by direct message, which is great. Thank you so much for that. Only one brave soul, though, so far. So anybody else? Who wants to come on camera or on microphone and speak to the principle you would use to answer this question? What part of the coding guidelines would be useful to know about for principal diagnosis sequencing versus secondary diagnosis assignment? Good, I'm seeing a few more. I'll give just a few more seconds for some others to respond. Okay, so some of you sent the right answer in. That's very good. Anybody who selected choice A, are you willing to let us know why you chose choice A, how you came to the answer? This session is for you, and the way our classes work is that you share that which you believe to be the basis for the answer, as well as why the incorrect choices are incorrect. If you're not comfortable speaking, you can certainly type your rationale in the chat box. Why do we sequence the malignant neoplasm of the colon as the PDX here and the anemia of neoplastic disease as a secondary diagnosis? Nobody? Right, very good. In this case, Robin, think of what has caused the anemia. In some instances, that's not the rule for PDX sequencing, but it certainly is for this particular part of the coding guidelines. So thank you for that input. Let's take a look at the official coding guidelines, which would be associated with anemia and malignancy. And I've given you a page reference here, pages 33 through 35 of the 120-page ICD-10 CM official coding guidelines. And you would be able to read about anemia associated with malignancy. We can see here that when the encounter for management of anemia is associated with malignancy, and we don't treat anything other than the anemia, you still sequence the cause of the anemia first, as long as the link has been made, so due to or with. So we can go back to the question briefly and look. The patient has colon cancer with anemia of chronic disease, so the link has been made by the provider documentation. And we even here explicitly stated hemoglobin levels have been pretty steady during recent IV chemo cycles, which means we're definitively not attributing a low hemoglobin here to the treatment regimen for the colon cancer or the metastatic disease, but rather to the anemia of chronic disease related to cancer. All right. So anyone that wants to get a little bit more involved in the next one, feel free to. I'm going to try and pull some of you out of your safe spaces. There's no judgment here. Nobody's going to say anything to you if you pick the wrong answer. It's the effort that matters, and it really only counts on test day that you get all of the questions correct. All right. Let's take a look at number 2, please. Anybody interested in sharing their answers to this one? I see one correct answer already, I think, somewhere. If you switch your text box chat to send only to me as a direct message, we won't all see your answers, which allows others to think about their choice without any bias. All right, a lot of you are picking choice C accurately for this. Remember that for new onset diabetes, due to the removal of part of the pancreas tissue, we're seeking a code to be PDX from the E13 series first. Secondarily, we will need a code for the post-procedural hypoinsulinemia that is overtly stated in this documentation. We're told, due to partial removal of the pancreas, we now have insufficient insulin production. And we also know that part rather than all of the pancreas was removed. So we have an appropriate Z code for that as well. All right, let's take a look at some of the wrong answers. If anybody might be willing to share with us by way of microphone or chat box entry, what is wrong with choice A, other than we know it's not the correct answer, but what makes it incorrect? How can we rule out choice A very quickly? This patient is a newly diagnosed diabetic, right? They've only developed diabetes as a consequence of having part of the organ that produces insulin removed. So if it's a new diagnosis of diabetes mellitus, why does E08.8, and you've got the description of the code there for you, why does that code not work particularly well for this scenario? Very good. There's no chronic underlying condition, Raven writes. Very good rationale. Unless you want to call the condition status post pancreatectomy partial. It's not really a condition. It's not a chronic condition that would lead to diabetes or anything like that. What else is wrong with choice A? It says unspecified complications. So not only is it that they claim it would be with an underlying condition fueling the diabetes mellitus, but it says unspecified complications are on board. What's the problem with that in light of these questions or in light of this question's setup?
Was it because they say the specified complication, the diabetes is the complication of the pancreas, the removal of the pancreas?
Well, it's a good thought. Here I'm thinking more specifically that if you are newly diagnosed diabetic, would it not take a little while for complications to manifest? So you're not going to get diabetic nephropathy or diabetic retinopathy or any other side issues that may arise with diabetes mellitus and poor glycemic control. So it doesn't work. It doesn't work to have an answer that claims to have complications of a disease for which complications take a while to develop. So for two reasons, you can quickly rule out A. You can see that choice B tells us that we would leave out the code for post-procedural hypoinsulinemia. Is there a problem with doing that? What about the metric impact on this record, if this were to be a record you were reviewing? What metric impact would you lose with choice B by not being inclusive of E89.1? So if you don't already know, E89.1 is a CC, complication comorbidity diagnosis. So you would be losing the impact potentially to a DRG assignment if there were to have been no other CCs on the record at that point in the admission. You would also potentially lose a few other factors, a few other metrics related to risk adjustment on the case as well. All right. So let's move on to the next one. Again, I don't want to dwell too long. Quiet group this evening. I hope you'll feel comfortable, judgment-free environment here to share your thoughts. And thank you, Raven, for all your input on this one. And Robin as well. Thank you. All right, number 3. Okay, I'm seeing a few replies coming across slowly. Keep in mind the ICD-10 PCS guideline document that you can download from cms.gov is only about 20 pages in total length. It's well worth you reading the entire document before taking the CCDS, as well as the 120-page ICD-10 CM guidelines. It's not that much reading to get through, and if you've got the requisite 2 years or so plus experience in CDI work, it should be quite easy for you to read through because a lot of the rules and regs there are part of your daily workflow and you'd already be well familiar with them. You might see that occasionally, though, you stumble into a coding rule that you maybe hadn't appreciated fully, or some nuance of the code set that helps you with a question. Okay. Let's take a look at the answer for this one. I think one person chose this by direct message to me. So you're welcome to come on and explain. We first have a core needle biopsy done percutaneously, and we also have a partial mastectomy performed at the same site after the frozen section reveals a malignancy, quite a common sequencing clinically. And the guidelines tell us here, page 7 out of that 20-page document that I mentioned under subsection B 3.4b, they give the example directly that both the biopsy and the more definitive treatment are coded. So that's not always the case, but in this particular case, the exact example illustrated in this question is in fact the one referenced. Biopsy of breast followed by partial mastectomy at the same procedure site. Both the biopsy and the partial mastectomy procedure are coded. So you may go through 3 or 4 PCS guidelines like this one and say, I'm good, I know that from my workflow, but you may come to one like this and find that you didn't know about this particular rule. All right. Let's move on then to number 4, please. I'm excited to see a lot of people sending in the right answer for this question. Can somebody jump onto the microphone there and share with us why you've selected the correct answer choice for this one, which is, oh, I haven't highlighted it. My apologies. But it is choice B. The principal diagnosis used for this case will be reflective of a relationship between hypertension and heart failure. What is that relationship that we're referencing here? Okay. Well, I know some people out there must know the answer because you've typed it in correctly in the chat box. But we are, of course, speaking here about the guidelines around combination codes, and presumed relationships certainly help us as well here. So let's take a quick reminder for those that don't know or confirmation that for those that do know, and perhaps are just feeling a little bit shy this evening, to share with us. That's no problem. Here you would reference pages 48 to 49 of the CM guidelines, section 9A1, and you will see that the classification rules presume a causal relationship between hypertension and heart involvement. So if that's the case, which we had in this case, a secondary diagnosis of hypertension, as well as the primary concern of a heart failure exacerbation, the code set, first of all, presumes that relationship and will also instruct to assign a code from the I-11 category. This will be I-11.0, hypertensive heart disease. And that will be the PDX for this case. The I-50 code, the appropriate I-50 code will be the secondary diagnosis, along with others, including hypertension and the others that were mentioned there. All right, so combination codes are important. There are not that many that are used in the daily workflow for CDI. What are the other combination codes that matter for heart failure? Are there any others?
With CKD or with renal involvement?
Perfect. Yeah, with renal involvement, now we're dealing with which PDX, which code?
It would be a combo code for the heart failure, the CHF, and the hypertension.
Okay, yeah, that's correct. So we'd be dealing probably with I-13.0, should there have been CKD. If you notice, this patient had acute kidney injury. What do you think about acute kidney injury? Can it also apply to the combination code? It does not. Good. Oh, lots of no's. Good. Affirmative responses there. Yeah, correct. There's no rule here for AKI. We're talking about different stages of CKD potentially being present and feeding into a different combo code PDX. Very good. All right. Good. Let's move on to question number 5 then, please. For those of you that selected choice B for this question, uh, what is the difference between a physiological ileus and a paralytic ileus? Ileus is certainly a CC when it's clinically valid. What are the criteria that you need to use to decide that somebody has a true paralytic ileus as a complication after a surgery? How many days after a surgery might you expect a physiological ileus because the abdomen was manipulated. These are the things that you'd need to think about to answer this question. iPhone user, did you mean 3 rather than 30? I'm thinking. Okay. We have a clinically invalid diagnosis here and would require further inquiry by query to resolve. Physiological ileus is expected up to 72 hours after a procedure, particularly with opioids on board, which can cause a fair amount of constipation, and particularly because the patient's bowels were manipulated. It's a little early on post-op day 2 for the surgeon to already be documenting paralytic ileus, and then also mentioning the patient's symptoms are likely related to post-op bowel hypoactivity, which might be a description of a physiological ileus. So we have a rather perplexing provider entry there to contend with. And as such, you would need to query for this because we don't have a valid secondary of ileus here. We don't know which ileus they mean. We certainly don't have a valid post-op complication diagnosis, choice B, because the timeline is incorrect. We certainly would never make ileus the PDX in this case. It would be whatever necessitated the procedure in this case. So we have a clinically invalid complication. Any further thoughts on this item? Questions, comments, objections? You're allowed to discuss, you're allowed to push back. That's part of the learning process as well. All right. Thank you very much. Very good. Let's move on then. Number 6, please. What's the comorbidity impact of shock when it remains unspecified in the way that it does here for question 6? Is it a CC and MCC? Neither. Can't be both. Unspecified shock is a CC diagnosis. How about specified shock? Cardiogenic, hypovolemic, septic, anaphylactic. Right, now we get MCC value out of the case. So when we specify the underlying etiology of shock, or in particular link it within the documentation, then we can fully capture the proper secondary diagnosis impact. So very good, those that were on top of choice B here. The pathophysiology underlying the documented shock is entirely evident here, with a low cardiac output, a compensatory tachycardia, very low mean pressures that required dobutamine. And unfortunately, the provider doesn't explicitly state that, and coding cannot pick up any particular type of cardiogenic shock from this story just because it looks like it's the case. So we would like to have seen some commentary as to what caused this shock, which certainly looks cardiogenic in nature. Probably it's a systolic CHF exacerbation, but it doesn't have to be. We don't know from a small case synopsis like this, but certainly it doesn't matter for the answer. Choices A, C, and D all have value, potentially, for this case. But what do they do for the case? They don't define shock, do they? A particular type of shock. They do clinically validate a particular type of shock. So if you have a specific type of shock, some of these other elements that we see here, such as wedge pressures and drip rates for a target map and all the rest of it, certainly could clinically validate a diagnosis, but you would not make that CC to MCC shift without a query to clarify shock etiology. So that was the point of this question. Very good. Thank you, those that jumped all over this one correctly. No need to hesitate on the next one in that case. Looks like some of you really are on top of your knowledge, which is great. Let's look at number 7 next, please. Must we have a CD4 count below 200 to sequence HIV
Thank
as
you.
the principal diagnosis?
Okay, thank you. Do you need a pin?
Yes.
No.
Is there any reason to sequence differently if the CD4 count were 205 or 250 or 300? What makes HIV, active HIV infection code B20, what makes it the PDX in this case? What qualifies it to be the PDX? Is it the CD4 count in particular? Sepsis is not going to be intrinsic or implied by a B20 PDX here for HIV active infection. You would still need a code for sepsis. Would it matter which opportunistic pneumonia is revealed as the cause of sepsis along with the active HIV infection itself?
I think, yes, if you get a more specific pneumonia, we need more specificity.
You need more specificity to code the pneumonia, certainly. But would it have any bearing on PDX assignment?
No.
It wouldn't. That's right. If you have an AIDS qualifying condition like Kaposi sarcoma, we're not really particularly interested anymore if the opportunistic pneumonia is specifically pneumocystis jirovecii or some other sort of opportunistic pneumonia common to HIV infection. We have a clear link between a presentation of lost viral control, positive HIV, active HIV, and we have the qualifying condition of Kaposi sarcoma, which means sepsis will always be secondary to HIV in that scenario. Okay, so you must remember for CCDS circumstances in which sepsis may not be the PDX. It's often the PDX, more often than not. But we know certain circumstances, like when sepsis is POA and we have a catheter-associated UTI, for example, complication PDX rule may kick in to make sepsis an MCC on the case. So here we have another rule being applied. Remember, you also have poisonings, obstetric cases, other circumstances where sepsis may be secondary. All right, good. Let's move on to number 8, please. Remember, you can use your DRG expert book on test day. You can use the book as long as you don't put any post-it notes or staple anything to the pages or scotch tape anything to the pages. You're even allowed to scribble some notes in the blank portions of your favorite DRG expert book. So you'll have the ability to use that. But is that the best day to start learning commonplace DRGs? Probably not the best day in the interest of time management. So some of these ranges of DRG should be familiar. Rectal resection. Is it a major bowel procedure? Is it a minor bowel procedure? Is it its own bowel procedure that has its own DRG family? What do we think here? I see a mixture of different choices coming in. Appreciate the participation. Sometimes we not only have a silent, all silent on the microphone front, but we also don't get that much chat box activity. So glad to see that you're engaging this evening. Wonderful. Okay, those of you that selected choice D for this one are correct. Let's take a look at the details here. So the DRGs of interest here kind of come in 4 potential regions. We could have had a minor or major bowel procedure with MCC. We might have thought about the fact that the lysis of adhesions was so extensive for this, but we also had rectal resection. Rectal resection is the definitive cure, the definitive treatment in this case for colorectal cancer. So you'll certainly have a code for lysis of adhesions because it's extensive enough per the question stem that you would not consider the lysis of adhesions necessarily integral to the procedure, especially when the provider bothers to mention that. But in the end, the principal procedure is not the LOA. The principal procedure here would be rectal resection, which has its own DRG family. And you can see here we have with MCC. So all of the answer choices here were with MCC, the MCC, of course, being acute tubular necrosis due to hypoperfusion. I recommend before you take the exam that you become familiar with the major DRG families that are commonplace to daily CDI work. You don't have to know the whole set of DRGs out there, but it's a nice thing to become more familiar than just the common ones, like the 870 to 872 series for sepsis, the 193 to 195 for simple pneumonias, the 177 to 179 for more complicated pneumonias, so on and so forth, 280 to 282 for MI, 853 for surgical sepsis. We all know those ones. We deal with them every single day, but you sometimes deal with these as well. So if it's a reasonable volume that you're reviewing that groups to a particular DRG family, better to get to know that family in advance of the exam so you save time for more difficult questions rather than flipping through the pages of that book that frankly have tissue thin pages. You can easily rip them in the excitement of the exam day or just have a hard time getting flustered looking for those things when you're under a time limit. So practice learning, take a few notes if you need to on which types of procedures go to which types of DRGs. All right, let's have a look at number 9, please. The mortality index is not, you won't have so many questions about the mortality index, but it will come up in some way, shape, or form on the exam. Keep in mind it's the observed over the expected mortality. That expected mortality is not the same value as the risk of mortality that you calculate on the APR side when you're looking at SOI and ROM, for example. So in this case, expected mortality, the risk-adjusted expected mortality in the denominator of the mortality index is calculated using a linear regression model, and there are updates each year on which diagnoses contribute to expected mortality. Keep in mind, they're not always CC and MCC diagnoses. That's why you might review a chart, and you may have heard management sharing with you that if your case is already so-called maxed out at a 4 and 4 in a DRG, maybe you've got surgical sepsis sitting in 853 with 4-4 SOI ROM, you may see that case as so-called maxed out, but you still keep reviewing the chart. You shouldn't push it to the side because you may pick up risk-adjusted expected mortality diagnoses, which are not always CCs and MCCs. That's the idea of this story. Can we control observed mortality? We cannot. So the numerator of the mortality index, observed mortality, is simply an observation of how many people passed away for a particular service line or facility or provider in a fixed amount of time. And the expected mortality reflects the calculation for that same patient population, considering all comorbidities, not only CCs and MCCs, but some other elements. You'll see things like ventilation required on admission day. Some of them are things that you can't control, like gender and age. And sometimes you see chronic comorbidities that are HCCs or some that are not even HCCs, and they can all play a role. So you can't do anything to the observed mortality, so A is not the answer. The omission is not going to do anything to the numerator, which is observed mortality. It's whoever dies, unfortunately. Let's look from the bottom here. Choice D, the omission would lower the expected mortality contribution. No. Stage 4 CKD, if included, well, it would certainly lower the expected mortality contribution, but omitting a CC would not improve DRG weight, and it would not help with resource allocation. It might have no effect on DRG if there's other CCs like stage 4 CKD on board. But certainly wouldn't improve DRG weight to omit CKD stage 4. So good. Those of you who are thinking about choice B, sending me private messages, if you leave CKD stage 4 off of the diagnosis list, you therefore would lower the value of the risk-adjusted expected mortality in the denominator. Lower denominator means you inflate the overall ratio, the overall mortality index. Keep in mind, we hope to have a mortality index of 1.0, meaning that patients who pass away in the hospital were expected to do so based on the profile of their comorbidities that they bring to the table. And for AMI, and for anyone that would go on to need coronary intervention, there's a huge impact for having CKD stage 4 versus earlier stage CKD when it comes to the expected mortality for many of those procedures. So this is the reason that B is correct. Choice C, the omission would not impact risk-adjusted expected mortality. We can stop reading right there because it certainly would. All right, we're up to the last question here. Final chance to contribute. Get on the microphone, come on camera. Let's see who wants to engage here today. Keep in mind, for any diagnosis to impact any metric, whether it's the impact to relative weight of the final DRG assignment, whether it's the SOI ROM, whether it's this concept of expected mortality, what must be true? It must be that the condition is clinically valid. If the condition is not clinically valid, it cannot be used. What makes the provider's documentation problematic here is they've documented chronic respiratory failure, but they've not mentioned baseline oxygen dependency or room air oxygen saturations without that O2 or any sort of qualifying blood gas value, be it venous or arterial for that matter. There's really nothing here besides the provider say so that this is chronic respiratory failure. That's not good enough to pick up the code. So choice A is correct. The others, that we would somehow still assign it as a code even, let alone if it affects risk-adjusted expected mortality, you shouldn't even assign the code to pick up a CC for this condition unless it has clinical validating criteria. And we're told clearly in this question that it lacks the necessary clinical validation criteria. So we would not choose to risk adjust with it. The single ABG edition is insufficient. And it most certainly does matter if there's a clinical validation gap in the documentation and those indicators are not pulled through in the assessment and plan. So only choice A makes sense for the question. And in some cases, for any exam that's standardized, you may need to eliminate and pick the least offensive answer choice, which choice A certainly is, even if you didn't have all of the ingredients in your mind necessary to get the correct answer, you could certainly get there. So that's what we have time for as we come close to the top of the hour this evening to discuss together. I definitely appreciate the attendance tonight and your participation as mentioned. If you're interested in working with us, we do have some spaces left in our upcoming live online class, CCDS exam prep course, March 3rd and April 7th. We do have payment plans available. We also have an April 7th start date with a few more spaces remaining. And in the month of April ahead, we will also be excited to release our self-paced version of our course, which has a slightly lower price point and also includes still 6 hours of live online guidance regarding your diagnostic tests, your mock exam, and all of the assignments that come across the 15 modules of the self-paced version. And if you're just only interested in the diagnostic tests and don't really want a course, then you can always just take our diagnostic test as a freestanding product as well. We offer that. With just a few minutes left, I'd love to know if any of you want to ask any questions, share any feedback. Otherwise, I am very grateful to all of you for attending. Thank you so much. Please do feel free to email us at info@cdiqconsulting.com. We'd love to know what topics you'd like to see in the upcoming March webinar. We'll have that in the third week of the month, next month as well, just like this. If you can't think of anything specific, no worries, we'll come up with a topic, but do feel free to email them or pass comments on our Facebook page when we advertise the March event. All right, if there's nothing else, then we'll sign off for the evening. And again, thanks to everybody in attendance today. Really appreciate your time. Take care, everybody.